in the country, Dr. Jeff Caney of the University of Wisconsin. He's the chief of thoracic imaging there, and he's very highly published and very well known in chest radiology circles. And, you know, I came to him early on when I was in New York, and I called him one day because he and I were close. We'd worked together closely as a pulmonologist and a chest radiologist. And I said, Jeff, you know, what would you say if I told you that I thought that everybody with COVID had organizing pneumonia? And he said, yeah, we already know that. We published that in March. And I said this to him in late April. And so I said, are you kidding me? He told me that they had published an expert panel paper in the Journal of Radiology in March. And I said, you know, the clinicians never got the memo. Nobody understands that this is an organizing pneumonia. And so I want to talk about organizing pneumonia for a few minutes. If you go to the next slide. So organizing pneumonia, what I call OP, it's really the worst named disease ever. Nobody can understand what it is because everybody thinks it's a pneumonia, meaning an infection. And it's not an infection. And organizing pneumonia, it's really a pneumonitis. It's a pattern of inflammation or reaction to some sort of lung injury. Sometimes it's idiopathic, so we don't know the cause. You just find this pattern of inflammation in the lung, and it has very characteristic radiographic patterns. And when you don't know what causes, it's called COP, right? So cryptogenic organizing pneumonia. Or if you've been around as long as you and I have, you remember the term BOOP, right? The disease BOOP, which is bronchiolitis obliterans organizing pneumonia, right? So it's actually a fairly rare lung disease. Pulmonologists know it best. And I'm going to tell you, as a pulmonologist, even amongst pulmonologists, many of them don't really get a good feel for it because it's a kind of a weird disease. So what it is, it's a pattern of lung injury, and it's strange what happens. So what happens is all these fibroblasts and myofibroblasts fill the alveoli and the alveolar ducts. And I know the cool beans know what I'm talking about because they know their anatomy, they know their immunology. I've seen your talks, Dr. Bobine, and so I think that these are easy terms to understand. And they fill those ducts and alveoli, and then they kind of form like collagen, like granulation tissue, almost like a healing pattern. And the problem is, but they fill those places, and so it impairs gas exchange, right? Now, what people don't realize is just as common as the idiopathic or cryptogenic form is, there's a lot of things that cause it. And when you see it, when you can identify the cause, we call it secondary organizing pneumonia. And probably the most common cause of secondary organizing pneumonia is an organism. So viruses can cause it. In fact, in the prior pandemics, it was increasingly being recognized. So in SARS, in one paper, in one ICU, they had between 30 and 60% of the patients who they found on biopsy actually had organizing pneumonia. And that was in the first SARS pandemic. And then also there were reports from H1N1 and MERS. So these viral pandemics, we know it causes organizing pneumonia. In COVID, I find it's almost uniform. And so if you look at the autopsy series of patients who die of COVID, very rarely do you see actual cytopathic damage from the virus. It's all, it's actually, well, the autopsies actually show DAD, which is diffuse alveolar damage, which is really just the end result of all lung injury. So if you die of lung injury, it's always going to be DAD. So it's not very helpful when you find DAD on an autopsy because you don't know what that progression is. And what's interesting about COVID respiratory disease is exactly no one ever did an early lung biopsy. No one, you know, everyone thought it was a viral pneumonia. Why would you do a biopsy? They were COVID positive. They were sick. They looked like everybody else. And so no one really actually proved that it's organizing pneumonia. So how do we know that it is? Well, a couple of reasons. Well, number one, it behaves like it clinically. You have these ground glass opacities, and they appear and they're characterized in a pattern that's very consistent with organizing pneumonia. It has a very unique archetypal pattern, and so almost all the CAT scans show this organizing pneumonia pattern. The other thing is, and this is how I first made the association, is that this phenomenon of silent hypoxemia, or what people call happy hypoxemia, which is these very low oxygen levels, but the patients look okay, they're not struggling to breathe that much. That's where it kind of clicked in my head. I said, you know, they remind me of my organizing pneumonia patients. You know, as I take care of a lot of patients who are, you know, a lot of lung cancer drugs actually will cause organizing pneumonia. And some of those patients, when they get sick, they're in the hospital for weeks on high amounts of oxygen, but they look okay. They just need tons of oxygen. And I was like, you know what, that's what these guys look like. And so that's how I first made the association. So next slide. And so, for those of you pathology geeks out there, this is what the air spaces when they fill. It looks like collagen, so it's collagen filling air spaces. Normally, they should be open; they should be lumens in air, but these distal air spaces get filled with collagen-like material. Next slide. And I use this term palm to forehead, which is what that sort of anecdote that I just told you, which is that Jeff Caney, who was the lead author of the the lead author of this expert panel, they published in March, and in that position paper where they reviewed all the CAT scans coming out of Wuhan, they wrote the most common reported CT findings in COVID-19 patients are typical of an organizing pneumonia pattern of lung injury. And I tried to publish my paper starting in April. It took me 6 journals. They all rejected it outright. They all thought it was a hypothesis. In fact, one major journal, actually was Chest, it went through peer review, and the reviewer rejected my paper, telling me they would only publish the paper if I did a randomized controlled trial of corticosteroids in COVID and proved that it worked. And then they would publish my paper. And like 3 weeks later, the recovery trial came out, which showed that corticosteroids were life-saving. And this is also one of the reasons why I argued, in the Senate back in May that the world needed to use corticosteroids. And I was ridiculed then, just like I'm being ridiculed now. Next slide. And so, yeah, if you play this, if you look, there's these, gray areas and black areas. And when you look carefully at it, if you could just play it, just let it go back and forth. You'll see these really strange and very sharp demarcations between the black and the gray. And that is really highly suggestive of organizing pneumonia, these diffuse bilateral lower lobe and well demarcated patterns of ground glass, right? So it's not consolidative where you can't see any of the lung markings. It's just this diffuse sort of ground glass picture. If you go to the next slide. And the thing is, there's only one treatment for organizing pneumonia. Well, I guess 2. One is remove the offending agent, right? So if it's a drug, and it's very common, it's secondary to a lung drug. It's really synonymous with drug-induced lung injury. So you remove the offending agent, and then you use corticosteroids. There's never been trials on OP with steroids. It's just what pulmonologists have done. And here's the things that I tried to argue in my paper, and I tried to tell the world, listen, this is a pandemic of organizing pneumonia. Number one, the mainstay of treatment should be corticosteroids. It took them a while to realize that. Now they realize it. But they are failing to really act on this insight, which is they're giving these very low doses of steroids. Even patients dying, crashing on ventilators. They're giving them like these anemic doses of dexamethasone, 6 milligrams of dexamethasone. It's a joke. I give 80-year-olds with COPD more steroids than that. And so they're using very low doses, whereas we know in fulminant cases of acute respiratory failure with organized pneumonia, case reports going back decades, you need to use pulse dose steroids. And if you don't know what that means, it means very high doses. Things like 125 milligrams of methylprednisolone every 6 hours or 250 every 6 hours, like a gram a day. And that's sort of my practice and has been for a while with the severe patients in the ICU. The second thing that I think the world, the healthcare systems are failing to recognize about disease is not only you need to hit them hard and high, but you need to go long. Organizing pneumonia is actually a smoldering illness that takes weeks and sometimes months to recover. You need to do prolonged doses of steroids, and you really shouldn't stop until the patients are better. And I've been traumatized by watching my whole experience caring for these patients of people stopping steroids while these patients are still sick, their x-rays are abnormal, they're still inflamed, they're still on high amounts of oxygen, and people are stopping steroids. It just makes no sense if you understand what this disease is. And so I think people are recognizing now you need to use higher doses, and you really need, my practice is I do not taper until they start getting better, and I taper along with their disease. It's like Paul gives the best analogy. He says it's almost like using a vasopressor in a septic shock. What dose of vasopressor do you use? You use the dose that fixes the blood pressure, right? So if they need high doses, you give them high doses. And as they get better, you go down. And same thing with steroids and organizing pneumonia. And I don't start to taper off until they're off oxygen. And then I generally taper over 2 to 3 weeks because we're seeing patients get readmitted. The last time I was in the unit in Milwaukee, when I did a month there, both on my service and my partner service, we each had like 8 or 9 patients. 2 or 3 patients on our service had been discharged from the hospital, off oxygen and off steroids, and a week later they were back terrible lungs. They landed on ventilators, and a couple of them died. And so they're dying of actually, I think, insufficient treatment and inadequate prolonged treatment. And so I really want to try to get that out there to the doctors that are listening. You got to go more aggressive with the steroids here. Next slide. And then I'll go a little bit faster. So this is from my paper. This was a crazy case. Actually, it was a physician. She was 37 years old, and she had been on heated high-flow nasal cannula, 100% oxygen. If you look at the CAT scan on the left, and you see these really sharply demarcated peripheral areas of ground glass, there's only one thing that does that. That's organizing pneumonia right there. That's slam dunk classic organizing pneumonia. And she was on 100% for 7 days, and finally they decided to pulse her. And they gave her a gram a day of methylprednisolone for 3 days, and she immediately started getting better. Oxygen levels reduced. And this was her after discharge, 1 week after discharge, showing a little bit of scarring and bronchiectasis, but largely much better and off oxygen. And so it just shows you that this disease is quite steroid responsive. What's the interesting thing about this disease is nobody really knows why it's steroid responsive, like why these fibroblasts and myofibroblasts and collagen, why this dissipates with steroids. It's a little weird, but it does. Okay, next slide. And so this is, I'm just going to belabor my point. If you look at the randomized controlled trials, which have used the different corticosteroids, and if you look at the column to the right, it's called number needed to treat. If you guys know how to calculate a number needed to treat, it's really the difference. So if you look at a mortality difference, so if you look at that first slide, this was a paper from Iran where they gave 250 milligrams of methylprednisolone for 3 days. So this is pretty high doses. And they noticed that in the control group, it was 5.9%. In the treatment group, it was 5.9%, whereas 42% in the treatment group. In the control group. And so you saw this massive reduction in mortality to the extent that the number needed to treat, which is that metric that we use to show how powerful a therapy is, that means for every 2.7 people you do that to, you'll save 1 life. If you guys know what the number needed to treat is for defibrillating someone in VFib, it's actually 2.5. So using that dose in this disease, in that trial, it was like you defibrillated someone out of VFib. And so look at the green boxes of number needed to treat when you're using methylprednisolone. Again, some of this is dose-driven. I think also some of it is drug-driven. I think we as a group strongly believe, and I'm sure Paul has talked to you about this, Dr. Mobeen, that methylprednisolone is superior to dexamethasone. If you look at this, the number needed to treat, 2.7, 6.2, 7.8. Then in yellow, look at dexamethasone in that ridiculous recovery trial where they gave 6 milligrams of dexamethasone. You would need to treat almost 20 patients to save a life in this Codex trial. And then here, if you're on oxygen, you need to treat 30 patients to save a life. And so it's really not very effective. So you just need higher doses, and we believe that the preferred drug is methylprednisolone. So this is just my slide screaming at the world, you're not being aggressive enough with this disease. I think too many people are dying from undertreatment. Next slide. And then this is just in the last couple of weeks. Finally, we had head-to-head trials. So this is the first head-to-head trials that I've seen. One of them, 86 patients in Shiraz, Iran. They did triple-blinded randomized controlled trial. They compared 2 mg per kg of methylpred versus 6 milligrams. Now, does that mean methylpred is superior or is the dose superior? I don't care. Look at the difference. The difference in survival. If you got 2 mg per kg of methylpred, you had mortality rate of 18%. It was more than doubled if you were on this anemic dose of 6 milligrams of dexamethasone. I tell you, it's just traumatizing when almost every hospital in this country has the protocol of 6 milligrams of dexamethasone. Nobody wants to think outside the box. Everybody just wants to follow the one trial without using clinical reasoning, and I just can't stand it. So, and then similarly, another one from Los Angeles just came up on a preprint where they compared patients who got 1 mg per kg versus dexamethasone doses, and they found that mortality was 16% in methylpred and 26% in that dexamethasone. So basically, my point is the best available evidence tells you go higher and go methylpred when you're treating this disease in the hospital.